Again, our next session is providing community-based nutrition services via telehealth for young children. It is my pleasure to introduce Dr. Kirsten Bennett from Bennett Nutrition and Consulting and New Mexico Quality Improvement Partnership. Kirsten is also the co-lead of our New Mexico State team. We'll review our CEU statement one more time and just remind everyone that this can be found on the attendee website under the CEU tab. None of our speakers have conflicts of interest to disclose. And just a reminder that you can claim those CMEs with a survey at the end of the day today. With that, we'll stop sharing our slides and turn it over to Kirsten for this session. Thank you.
Good afternoon in New Mexico. Good afternoon wherever else you are. It's my pleasure to be able to talk with you today about the work that I am doing in the community. Just a little bit of background about me. I am a registered dietitian, and I have been providing services to children with complex healthcare needs for the last 34 years. Actually started my career in the newborn intensive care unit and was a hospital-based ICU dietitian for the first 8 years of my career. After that, expanded to providing outpatient services associated with some subspecialty clinics at the University of New Mexico, and was working as an academic in the last part of my time with the university. 4 years ago, I decided to expand my early intervention practice. I had been providing early intervention services since 1993, but decided that spending more time with children and families in the community was the next step in my career. So that's what I've been doing. In addition, I also expanded the work that I had been doing at the University of New Mexico in the Department of Pediatrics around quality improvement in healthcare. So I continue to work with our Children's Medical Services, which is our Title V program in the Department of Health, and some various federally qualified health centers as an evaluator for some of their federal funding, HRSA funding, around services provided to young families with children. So that's a little bit about where I come from. And first of all, I want to thank the families and the providers who do engage in this work in the community. Families allow us to come into their homes and provide services in a slightly different way in early intervention. And, the other providers that I work with allow us to provide a very, very rich source of support for the families that we serve. For those of you who don't know about early intervention is Part C of IDEA, Individuals with Disabilities Education Act, and it is what happens for birth to 3. It is a voluntary program at no cost to families. If children then qualify, they can go into Part B, which is the early childhood pre-K programs, with the goal of helping kids be ready to start kindergarten without too many issues going on. So if we think about how the opportunity that we have in early intervention, thinking about how community nutrition services, and that's what I'm providing in the context of early intervention, how does that support what we're doing with children and families outside the genetic clinic appointments, which is where people are used to, receiving care, freestanding clinics or going to an academic medical center where they have specialists. In addition to that, how do we use that quality improvement lens, which many of you are familiar with and which is being used in the Mountain States funding to address challenges in managing genetic conditions in rural areas? I'm practicing in a rural state. And so that becomes even more important. And then lastly, because there's this focus on telehealth, how does telehealth enhance all aspects of genetic care? So it's interesting, prior to the pandemic, the full force of the pandemic, when we were all forced to provide telehealth services, our only means of providing services, I actually was providing services using telehealth because of the range of the number of counties that I serve. So I serve 6 agencies in the Albuquerque-Santa Fe metro area. And that's a large geographical area to try to drive around. So I was actually offering telehealth services prior to the pandemic. So some of the families, at least were used to that. And playing around with my slideshow here. So how does this allow us to do a better job providing genetic services? So I know the theme of this is connecting the dots, and it really is connecting the dots. And early intervention connects dots in a lot of different ways. One is stress. So we're in a family home. And one of the things that we do as providers of services for young children is really address and acknowledge the stress and trauma of having a child that's living with a genetic condition. And sometimes we're revisiting that almost every time we go in, allowing the family to share that they are still having difficulty and they still need support. And by being in their home, it creates a different kind of relationship. I think the other thing too is acknowledging that stress and that we're there to support them. The stress is still going to be there. The other thing is taking that genetic condition and putting into context of global development. So we are supporting optimal development in all domains of the child's development, not just in the one thing that we're focusing on. Yeah, I'm a nutrition provider, so I'm focusing on specific parts of that, but providing nutrition care and growth monitoring that's consistent with whatever the best practice guidelines are for that particular condition, but also doing that in the context of what's happening with that child globally. So I'm supporting the whole child and the whole family at the same time. So the early intervention model is a coaching model. So in other words, different from other kinds of therapy where a child might go to a freestanding clinic and get services for physical therapy, occupational therapy, or speech therapy, where the therapist is doing hands-on care for the child, where the parent at that point is somewhat passive. That's a different model than what we're doing in early intervention. We are actually coaching caregivers to do things within the context of daily routine. So we're supporting that developmental progress across all domains. For example, a kiddo that I saw this morning with a speech therapist. This child has some gastrointestinal diagnosis. And so I'm going with the speech therapist and we're dealing with the child's oral aversion to feeding, which impacts this child's growth. The parents' hesitancy and nervousness and anxiety around introducing foods that might potentially have a GI effect that's negative. But doing that while we're also spending time with helping the child learn to do self-help skills, which use feeding utensils or toys, and at the end of the session, actually engaging with play in other types of play with the child so that we've created a very positive experience. EI is transdisciplinary. So even though nutrition is my space, I also know something about feeding skills. I know something about self-regulation and how kids respond to feeding and eating and how that fits into the context of their lives. So we sometimes step over that line. So being comfortable with the fact that I have skills that are similar to other therapist skills, but also realizing when I get to a point that I need someone else to come in and making that referral. The strategies that we're using to support families are embedded in daily routines to maximize growth, not only in physical growth, but growth across all developmental domains. And that, again, is very different than a child coming to a clinic where you're looking at one aspect and saying, go home and do this, or this is what I want you to change. The fact that we're providing these services in authentic environments. So you go to someone's home, you can see that they're having difficulty with their tube feeding. You see that they're having difficulty with managing their pump. You see that they're having difficulty mixing a formula. You can do all of that with them in their home. School, daycare, and even community settings. So I think this model is unique in that we are able to do the whole child, whole family. So in New Mexico, when we look at how we do this via telehealth, we're the 5th largest state geographically. 32 of 33 counties are considered health provider shortage areas. And that's not just in the area of pediatric nutrition, which we have that problem too, but also in the area of genetic care. 30% of our population lives in a rural or frontier area, and that's rural or frontier is described by federal standards. We're ranked 49th in broadband access, and only 12.5% have access to low-cost broadband. So this became, it's always been an issue, but it was an even bigger issue when kids were trying to go to school during the pandemic. Communities had to leave Wi-Fi on at the library so that the families could go to the parking lot of a library and actually access Wi-Fi. Restaurants expanded it so people could sit in parking lots. There were buses that had equipment to allow kids to go to school. So this became a even more stark in terms of, you know, our leadership thinking about access to telehealth services when we looked at how it impacted education. We have some areas where access is better, the Northwest and the Southeast, but then we have large tribal areas. So we have 3 major tribes and 19 pueblos that are part of New Mexico. And so navigating those needs in those areas created additional challenge for providers. So if we look at how telehealth fits in this EI model, so again, that context that EI is a coaching model, it's not direct service. So in some ways, this was a perfect situation to see how this worked, because I can get a family and child in the kitchen. They can show me how they're mixing the formula. We can put the child in the high chair. They can be down on the floor. And a therapist can coach a family through routines via a camera. So in some ways, you know, this was, you know, a perfect setup for us. However, families sometimes, if they're new to EI, which again, we had a lot of families that were new to our program, their kids came home from the ICU to home care, and they had never experienced early intervention and didn't understand the coaching model because their experience had been with hands-on therapy services. They had to be introduced to coaching and strategies. And so the combination of a new method of delivering services, telehealth, with a new model of services that they hadn't been exposed to created some challenges. If the family had prior experience to telehealth, then it made it easier. If not, then we were also navigating that journey with the families. So coaching via telehealth is, again, a little more challenging, just like it is. Here we are, you know, speaking. We were talking right before our session about what it would look like if we go back to actually having all of these conferences in person. In person, you can see what the audience is thinking. You can see if the people in the back row are sleeping. You can see if their people are eye rolling. You can see if people are sort of with you or not with you. And right now, as a speaker, I don't have any of those cues from my audience. So it's hard for me to tell if this is actually what you want to know from me and whether or not you're engaged. So that creates a problem for us in a coaching model when you have a family in front of you and you're trying to use telehealth to actively engage them in the process. Families do prefer in person. One, that's the relationship. They like having somebody there. And they see telehealth as a supplement to services. So right now, as we're in this transition between being allowed to go back in the home, for me, the challenge is I've got about half my patients I'm seeing in person, and the other half I'm still seeing via telehealth for various reasons. One, families are still nervous because the younger children are not vaccinated. So that's an issue, even though the workforce is. Kids are going to school, the older siblings, they're coming home with illnesses, and then we have to convert visits to telehealth because we're not allowed to go into the home if anybody has any symptoms at all. So families see this as a supplement with the idea that we're going back. And for me, supplemental services, I can see families more often. So this is a really great opportunity because I can see someone in person and do a quick checkup with them in a couple of weeks without having to drive out to see them. Coaching via telehealth, again, you have to have families prepared for the visit, toys, positioning the digital device so that we can actually see what's going on. What are the expectations for the visit? And then having props. So you'll see me move down here for a second. I'll show you one of my props. I have actually a little baby in a high chair. So I had to go shopping on Amazon. So I have a doll to use as a prop for families when we're talking about feeding and eating. So those kinds of things are new because typically we use what a family has in the home to do that. So in terms of the opportunities we have, Access. So telehealth provides us access. Again, we have a rural population. We are working still under some pandemic restrictions. We also live in a place that's mountainous, so we have bad weather. Again, we're the Mountain States Regional Genetic Network, so we have swaths of land that is prone to winter storms and blizzards, as well as snow and ice. Family illness. So when a family typically would have to cancel because somebody was sick, we can actually still have a visit with them and have a high quality visit, which is different than somebody having to cancel a visit to go to clinic-based services and then potentially having to wait 3 or 4 months to get back on, get rescheduled. There's ease of scheduling. Ease of scheduling for providers to some extent, because it doesn't matter where you live. I can just stack up my patients for the day. And it addresses transportation barriers. And a lot of our families, again, living in a very large state, driving for 4 hours and you're still not there is a problem. And then some families actually don't have transportation, reliable transportation. So we've, created better access by taking some of these challenges and converting them to advantages in this case. The biggest challenge that we have is reliable internet and digital devices. So a lot of families are using smartphones to do their telehealth visits. There are a large number of young families who actually don't have computers in the home. They use computers maybe at their work, but they're using the smartphone to do everything. It's functioning as their digital device of choice. And if you don't have a good digital device and you don't have good internet, or you don't have adequate data, then that's a problem for these visits. So the other thing that we can address is frequency of visits. So I can see kids more often than they can be seen in a freestanding clinic, because I have that flexibility, and that's part of my part of the model that we're using. Outreach clinics in New Mexico are provided around the state by our one genetic provider at the university. So families do travel to more convenient locations. They're driving less than 2 hours to get to one of those visits. But the thing that I'm doing that's different is that I'm providing services outside the clinic, because there's one dietitian for the genetic clinic at the university here, and she has limited capacity. So what we've sort of done is looking at how I can support children who are living with genetic conditions that don't have need for regular laboratory studies to manage their nutrition. So if there's no metabolic component, where we're looking at labs, a couple times a week, once a month, that kind of thing to manage specialty formulas, then that's a perfect setup for me, because I don't have access to those lab studies on a regular basis. So as an early intervention nutrition provider, I can address complex nutrition care in the home environment and actually demonstrate how to overcome challenges in the home. And I also can include other providers. So we're providing coordinated nutrition care. So there is a handout that you have as a speaker handout, which shows the role of a dietitian in transdisciplinary EI care. So feel free to share that with folks. This was actually put together last fall by one of my graduate students that was working with me. And this was a way of sort of visualizing how she would work in that environment. And we've been able to use it to share with families and also other providers. The other thing that I can do is provide care that's a little bit more consistent, because again, I am able to see kids more frequently. So an example of genetic conditions with nutrition concerns. These are some of the things that I'm seeing. So microdeletions and duplications, some of the big ones here: Prader-Willi, Cornelia-de-Lange, Williams syndrome, DeGeorge syndrome. These are some things, these are kids that I'm seeing in the community that, if they were restricted to just a visit to the genetic clinic and seeing a dietitian in that setting, would not have access to the support that I'm able to provide once a month or twice a month for them over the course of 3 years. So we're able to address some growth concerns that, and again, these are broad categories, but giving you an example of taking a look at short stature, is that something that's related to actual feeding and eating, or is it something that then we need to make a referral to endocrinology for follow-up? I carry around a baby scale, my stadiometer, so I do very accurate measurements. I use skin fold measurements in my home visits. So I'm providing a very high level of nutrition and growth monitoring that then can be shared with the other providers if need be. So if we actually make a referral, we've got lots of data to share with the person we're making the referral to. You know, if you look at a lot of these kids, they may start out as low birth weight, they may have experienced intrauterine growth retardation, they may have delayed bone age, and again, weight gain and change in linear growth may be an issue related to all of these things. The other thing is that a lot of these conditions have specialty growth charts. So we're comparing a child's growth to those specialty growth charts. And again, something that we can share with the family on a regular basis to give them some idea of how well their child's doing. The other thing we're looking at is sort of overall development. So a lot of these kids will have overall global delay in all areas. So where does nutrition care fit into the care for these kiddos? Some of these conditions also are associated with intellectual disability. So feeding, eating, and support within the context of global development needs to be put in the place where a child is functioning developmentally. And hypotonia impacts how we are able to support kids in feeding and eating. So they may have dysphagia or oral aversion associated with a negative feeding experience or the inability to have a coordinated swallow. They may have dental and palate differences that make us change the way we're providing services. And these are things that we can do at home in EI. And when I say at home via telehealth, that are not necessarily going to be addressed in your several times a year visit to the genetic clinic. Other co-occurring medical issues, these conditions also potentially have cardiac issues. They may be dealing with neurological issues, renal issues, food allergies, and I just realized that that should be ASD instead of ADS. So autism spectrum disorder or ADHD are part of maybe what we're dealing with. So the work I'm doing is not being done in a vacuum for these kiddos. It's being done with the support of an occupational therapist, a physical therapist, developmental specialist, a speech therapist, a social worker if we need it. The other thing that's interesting is that some of these kids, even though they have a genetic condition that's been diagnosed, maybe at birth, they don't have any regular follow-up with the genetic clinic, these things don't get necessarily addressed. And I think that's the advantage of having someone like me in the community who has experience with these complex medical issues, because we can help families navigate that. And this is particularly true for kids with rare disorders. Again, they have a rare disorder. We don't really have protocols that tell us how to follow them. They may have been sent home with a G-tube, but nobody's taking care of them. And nobody's taking a look at growth and developmental progress in the context of just that specialty clinic. So I think that's an opportunity that we have here. And one of the reasons why I really like this work. We already talked a little bit about the monitoring. So again, we have more frequent visits for growth monitoring. We can provide short-term support and changes as feeding skills change. And we can follow best practice guidelines for routine care with children with genetic conditions. And this also means I then have conversations with the primary care providers who, because of the limit in capacity in our genetic clinic here, pick up a lot of the routine care. In terms of costs for telehealth, one of the things that was really a positive change in our family and toddler program, which is our EI program at the state level, reimbursements changed in pandemic to actually be the same as they were for in-person visits. So we got the same rate, and that's continued. So I think it's made it easier for people to continue to provide services because there's no loss to the provider. Prior to the pandemic, even though I did do telehealth, it was paid at half the rate because I actually wasn't in someone's home. There's no change in provider time with the family. So we're still spending 60-minute visits with our families every time we go. The travel time has decreased for us, and that may increase capacity because we only get paid for the time we're actually seeing the family and child. So we don't get paid for the time that we're driving between homes. So if I don't have to drive, then it means I can spend more time actually providing service. And that's not necessarily true for clinic-based providers, because they get paid to be there the time that they're there. So if we look at all of this through the quality improvement lens, and there is a handout for that too, and I noted from other speakers that you guys have gone over this, we can use this for looking at systematic changes for individual patient care. So you can use the Plan, Do, Study, Act for what's my overall aim. My overall aim is to have this child decrease their tube feedings by 50% over the next 6 months. So that's my aim. And we can actually use the Plan, Do, Study, Act lens to actually help the family come up with the plan that we're going to start with, what it is we're going to be looking at in terms of the do. We're going to, change the formula, or we're going to change from daytime to night, from nighttime to daytime bolus feedings. We can study, we're looking at growth outcomes as we make these changes, and we can decide whether something works or not. And so we can use that systematic lens that PDSA and quality improvement allows us to do for healthcare environments and education environments, but we can do it on an individual basis with families, which is very, very powerful because it's very, very objective. It also allows us on the system level to reimagine how we're going to use our resources that are already in place, including staff. So, looking at telehealth and support for genetic conditions in the community, for someone like me, I'm one person serving a 5-county area, so that makes a lot of difference. It also acknowledges that we're going to do different things in different situations, and that may require us to be very unique in our approach to things. It allows for providers and families to partner in approaches to care because we are going through that process with them. It also allows providers and provider agencies to alter delivery approaches, like we did in the pandemic. So I think that in that way, we've had a nice little space where we've been able to work. So in terms of family stories, and again, I'm going to be true to our time here. I think the thing that I've picked up on, and I'm going to sort of do stereotypical family, because we have some rare genetic disorders in New Mexico that if I was to talk about them, somebody might actually be able to identify the child. So I certainly don't want to do that. But one of the things that I see is, again, for kids who do not have a metabolic component to the disease process or to the genetic condition. Say, for example, children with Williams syndrome. Part of that syndrome is potentially an alteration in calcium metabolism. So you have kids who are on specialty formulas. If a child doesn't have that particular component, then they don't have access to, in New Mexico, the dietitian who's connected with the genetic clinic, because the capacity for her to manage that group that doesn't require the routine labs makes it very, very difficult. So that's where I come in. I've been around for a long time. I know all the people, most of the providers in New Mexico, and I can share that with the family and say, you know what, I know who your genetic provider is, and I will let them know that we're working together and we can work on feeding and eating. We can work on growth management. And I can even share that back with your provider. And so I think from the standpoint of what we're able to do in a coordinated way, providing services for children living with genetic conditions that encompass a larger array of developmental concerns, I think is really, really powerful. So when we're going to the Q&A portion here, thinking about, is there anything that was new or surprising, about, the things that I shared with you today in terms of early intervention and transdisciplinary practice, and how you would see maybe a different way of using people like me in the community that maybe you haven't thought about. Maybe you didn't even know that those people were out there. When I started working in early intervention, I had an experience with my oldest child, but as an ICU dietitian, I didn't even know early intervention existed. I was focused on the kids in the hospital, and that's where I spent 8 hours a day for 5-6 days a week. I didn't think about necessarily who might provide services for them when they left the hospital, which is why I morphed my career to do more outpatient and more clinic-based services, because I felt like that's really where families needed the most support. And thinking about what questions you have after what I've shared with you. Are there things that I'm missing? Are there things that you would like us to see do differently? And then potentially, how would you access the EI agencies that maybe are in the area where you're practicing? And is there anything that we talked about today that you might actually just use right away? Like, again, get after this session, say, hey, you know, there's this kiddo that I saw and I wonder if they qualify. I wonder if they're getting services. So one way to think about answering questions when we get to the Q&A session. So I am going to turn this over to Christy now, because I think I'm pretty close on my timer. And if you have questions, I'd be happy to answer them. And I think, Christy, you want me to stop sharing at this point, correct?
That would be great. Thank you so much, Dr. Bennett, for your presentation. And we have a number of questions that have come through, so I will start reading those off to you. The first question is, are you able to be reimbursed for the more frequent visits with families via telehealth, or are there some restrictions?
Yeah, that's a really fantastic question. And for those of you who are not familiar with the early intervention process, or IDEA, which is the Individuals with Disabilities Education Act, that is a federally and state funded program. So there's no cost, but there are lots of rules around it. And one of the things that happens in the early intervention phase is we develop something that's called an IFSP, an Individualized Family Service Plan. And hours are agreed upon by the family and by the qualifying conditions. So the maximum number of hours a family can receive is 16 hours a month. And that can be split up among all providers. So if what they need is me, I can have lots and lots of hours. I can see that family once a week if that's what they want, or once a month. So that's something that we decide. And so there's no restriction other than the total number of hours that we have available for services.
Great, thank you. And the second question we have is, have you seen an increase in caregiver fatigue? My child has CASC, and although I love telehealth, I find that I am exhausted by the end of the day.
Yes, that is a very common reflection on families. It is so much harder for them to be, you know, when we're there in person, we're coaching them, but they're doing everything. We're not able to help them. In other words, I can't go rummage in the toy box and look for something that I want to use as a feeding tool. I have to ask them to go do that. And so, yes, they are tired. And if you think about even just this context of us having doing a virtual session, that's harder for the presenter, because one, we try to be organized and kind of get a sense of what the audience feels like they need, but we don't have any feedback. So in that telehealth, we're missing some of that feedback. And so as providers, we may not be picking up on that fatigue that caregivers have. And I think some families, when they tell us, it's really helpful. So I tell the graduate students I work with, I learned how to do a lot of what I learned how to do because I had families say, Kirsten, that is the stupidest thing you've ever come up with, or we're not going to do that. So if you feel like you are bold enough to do that, share in a nice way with your providers that this isn't working for you, or there might be a better way to do it. And again, that's using that quality improvement lens to navigate where we are now, because it is hard.
Perfect. Great answer. And question 3 here is, how have you found families' readiness for telehealth? Do you interact with new families at this point in the pandemic that need coaching on the technical aspects of how to even do a telehealth visit? Does the EI agency prep them for this, or is this up to you to do as well?
That's a fabulous question. Prior to the pandemic, it was up to the provider to coach the family on how to use telehealth. What mechanism we were going to use, how to set things up. And we still do have to do that to some extent. Like if I do a telehealth visit with you this afternoon, I want it to be a lunch meal. So let's make sure you have everything ready to go. So we're doing lunch. What's happened in the pandemic is that because early intervention program is, again, federal funding, and you have some rules, and we have all these papers that we have to fill out, the family actually has to give consent for services to be provided via telehealth, and they now also have to provide consent for services to be provided in person. So as part of that, the family service coordinator talks them through this. So we are much more structured now in the way that we prepare families.
Great. And just a little bit of a follow-up, because you mentioned your funding. Someone said, I may have missed it, but how is your program funded?
So this is all federal funding for early intervention under IDEA, Individuals with Disabilities Education Act.
And then another follow-up to that, can you remind everybody what the age limit of the services are through?
Yes, so for early intervention under Part C, it's birth to 36 months. So at 36 months, kids are no longer able to receive services. But again, because this is a very structured program, we start the transition process when a child's 30 months old. So there's actually transition to the public school if we feel like that's going to be needed, or to a specialty school, say a school for the visually impaired or school for deaf and hard of hearing, or to a developmental preschool, or if the family would prefer a private preschool. We do all of that transition. So we do actually have some hours after 36 months. Pandemic, they gave us more. In the old days, it was 4 hours that then we could go into the, like a daycare or the school setting and coach the new teacher or the new provider in that new setting after age 36 months.
Great. And this one's a combination question and comment. My interest is really piqued on this because I have a 3-year-old child diagnosed with chromosome 18 deletion who is only able to feed purees through a bottle, no GI tube. How can I find the service in my area of Dallas to try before resorting to more severe methods?
So remind me again, how old is the child?
3 years old.
Okay, so 3 years old, you know, again, from the standpoint of early intervention, unfortunately, you know, you've come to the end of that. And just as a plug for the services, a lot of families don't know about this service. And this is a self-referral, so, or a provider referral. So in other words, you don't have to have a referral from your pediatrician. You can call up early intervention and say, hey, I'm concerned about my child's development. And no cost to you, all of the testing and everything will be done by the agency. So just share that with the families that you guys are working with. After age 3, again, your best probably course of action is to go to your primary care or your specialty service provider, your genetic provider, to ask them what the nutrition and feeding environment's like where you are. Dallas is a big city, so you've got lots and lots of options. So there'll be some private feeding clinics, therapy centers that have SLPs associated with them to work on feeding.
Great. And last question, I think, as we wrap up here. Excellent presentation. How many other dietitians in New Mexico are providing this type of service and using telehealth?
So there you go. You got me.
The one and only.
The one and only. Several years ago, there was someone in Santa Fe who was starting to do this. I don't know if she's still doing this. There are a couple of agencies that sometimes will provide, you know, one-time contracted services. New Mexico, like I said, is that we have a lot of antelope here and a lot of cows and not very many people. So it's a big geographical area. So, you know, one of my strategies maybe in this coming year is just to address all the agencies. So we have 43 early intervention agencies in New Mexico. So there's one in every, you know, county, and some have more than one. Some are private, for-profit, and some are nonprofit agencies. So this is a real problem, you know, in terms of access. The other thing to keep in mind is that some states do not include nutrition as a service in early intervention. So states have some control over how they use those federal dollars. I know I talked with a group of dietitians in Tennessee, and Tennessee is one of these states that doesn't have or did not have nutrition as part of their early intervention picture. So that's another thing to keep in mind.
Great. Well, that comes to the end of our session time here. Again, thank you so much, Dr. Kirsten Bennett, for your amazing presentation today and for your leadership on our New Mexico state team.
All right. Thank you. It was my pleasure.